Welcome everyone to the eMedica MRCGP AKT High Yield Revision Webinar number 3 for the January 2024 exam. So in terms of the format today, we're going to cover exam style questions covering key topics followed by rapid reviews. There'll be examples of questions from all three domains: stats, admin, clinical. I'm going to split it into 3 parts. So part 1, we're going to do 5 interactive questions where I'll show you one question at a time. You'll have 55 seconds to look at it. Then I'll launch a poll and you'll use the poll to answer. Part 2, we're going to do a 10-question timed mini-mock exam. So you get used to answering questions coming from different topics and what does the optimum pacing feel like for those on standard timing. Then part 3, we'll talk about revision planning, how to make the most of this critical period. We're about 7 weeks to the exam now, aren't we? Okay, so it's a really important part of your preparation. And then if you've got any questions, there'll be a live Q&A at the end. So use the chat to get involved in the comments and discussion. Only the faculty can see that. Use the Q&A if you've got questions that you'd like myself or the team to answer. Joining me today on the faculty to answer questions from the core eMedica team, we have Masuda Rahman, Anna Greathead, and Laura Smith. So let's get straight into it. I'm going to go straight into question number 1. You'll see the question for 55 seconds, and then I'll launch a poll. Here we go. Okay, that's time. Please select your answer from the poll. Okay, good. So there's a split between A and C. Okay, so all of the options have been picked, but the 2 that are the most popular, A and C. Okay, so the correct answer is A, that hearing in the right ear is mostly in the normal range. Okay, so this is the normal range. Okay, once we get under this line, we're losing some hearing, and then once we get under 40, it's more significant, and then here is very severe loss. Okay, so now the first thing is to know the standard way that audiograms use color. So the right ear is in red. If it's in color, the colors are always the same. The right ear is always in red, R for right, and the left ear is in blue. So this is the right ear. Can you see? Look, if this is normal, you can see for almost all of the frequencies, all the way up to here, it's still normal. Just right at the end, at very high frequencies, this is way above 6 kilohertz, you've got minor loss. Okay, so you can see the right ear is mostly in the normal range. If we look at the other popular answer, which is C, that this is consistent with a conductive hearing loss in the left ear. Well, in a conductive hearing loss, what you'd be shown is both bone conduction and air conduction, and you'd see a gap. And I can see why those doctors that have picked C, you probably thought that one of these was showing air conduction and one of these was showing bone conduction, and that there's a gap. That's not the case. Bone conductions are always shown with brackets, either triangular brackets or square brackets. So if there was a conductive loss in this ear, what you'd see is, because there's definitely loss in the left ear, what you'd see is another blue line, and instead of crosses or circles, you'd have brackets, and that would be in the normal range. So you'd see blue with brackets here, and then that would be what a conductive loss would look like. Okay, so let's look at audiograms. So bone conduction is always shown with brackets, either square brackets that look like this or triangular brackets that look like this. Air conduction, one ear will be shown with a cross, one ear will usually be shown with a circle. And then when they're in color, they always use colors in the same way. The right ear is always red, the left ear is always blue. So in a conductive hearing loss, this is what you'll see. For a given ear, so in this case, there's a bilateral conductive loss. So you can see like the left ear, You've got loss here, and look, the blue brackets are the left ear's bone conduction, and there's a gap between both. So bone conduction is normal, air conduction is reduced. That's what you see in a conductive loss, right? In a sensory neural hearing loss, what you'll typically see is they don't bother showing the bone conduction. That's because we don't care about it. Okay, they just show the air conduction, right? Now, what do you think is being shown in this audiogram? Type into the chat. What type of hearing loss? And is it left ear, right ear, both ears? Anyone want to give a specific type of hearing loss that's being shown here? This is the very typical picture of presbycusis, the hearing loss of old age. It's usually bilateral, and it usually affects the high frequencies. It's the most common cause of sensory neural hearing loss that we have in the UK. Okay, so that's what presbycusis looks like. This is an example of bilateral conductive loss. In this case, this was a unilateral sensory neural hearing loss. It's only one ear that's affected. The right ear is largely normal. The left ear is affected, okay, significantly. Okay, question number 2. Okay, and that's time. Right, so this time there's a split 3 ways. Okay, A, B, and D. All 3 of these are popular and, to be honest, similar. Very few people picked C, very few people picked E. Now, this is an example of something that you'll see a lot in the AKT, which is it's a 2-step question. So the mark is asking about the most suitable management, which is actually step 2. The first step is working out the diagnosis. And the question could ask you that. So in a 2-step question, if you get the diagnosis wrong, a lot of times it will mean that you're going to get the management wrong. So type into the chat, what do you think the diagnosis is? What if this question was asking, what's the most likely diagnosis? Okay, great. So most people have got the diagnosis right, that this fits with epididymal orchitis. Okay. Now, a few people, you see, they've got different diagnoses, which might lead to you picking one of the incorrect management options. So some people thought it might be torsion. Some people thought it might be prostatitis. So that might lead to getting the wrong management. Okay, now, in terms of epididymal orchitis, there are a couple of variants of that. Try to think about which variant's likely. Type that into the chat, and I'll show you the right answer. So the right answer is D. Treat with levofloxacin, 500 milligrams, a 10-day course. Okay, a couple of things here that are really important for those of you thinking about which variant it might be. See, he's recently had a UTI. You can get it caused by organisms that are common in UTI, or you can get it secondary to organisms that are commonly seen when someone has an STI. This patient probably is less likely to have the STI variant, right? Because he's not been sexually active in the last month. And then one of the key things that's going to help you separate this as epididymal orchitis rather than being torsion, in terms of which is more likely, one is the presentation and the age. So he's had this for 4 days and the pain hasn't changed much. He's got mild tenderness on examination. How would the tenderness be described in torsion, typically? It would be excruciating, okay? And it's very unlikely that someone would wait for 4 days because the pain tends to be so severe. It's likely that they would have come more quickly. So that's one clue. And then this is the other giveaway, Pren sign. So Pren sign is when you elevate the scrotum, thereby elevating the testes. And if that reduces the pain, that's Pren positive. i.e. the pain is relieved with elevation of the testes. That's Pren positive, which is what you typically see in epididymal orchitis. In torsion, it's usually negative. That's if they even let you elevate it, because if you touch it, it tends to be so severe, they scream out in pain. Okay, so that's why the correct answer is this. Okay, so if you think about epididymal orchitis, it tends to have a more gradual onset. It's painful, it's tender, but that tenderness isn't usually excruciating. There will be a palpable swelling, there will be overlying erythema, and Pren's sign is usually positive. So that's when you elevate the scrotum, thereby elevating the testes, and the pain gets better. It doesn't go away completely, but it improves. So in terms of management, if someone was really acutely unwell, systemically, very severe symptoms, they might need admission. Otherwise, we either refer them to GU clinic if they can be seen within 24 hours, or if they can't get an appointment that quickly, or they don't want to go to GUM clinic, we can treat them in GP. And you treat based on the likely cause. So if you think the likely cause is related to STI, so gonorrhea, for example, then you might be thinking about things like ceftriaxone. If you're thinking about, some of the other STIs that also might be indicated, things like chlamydia, you might think about other treatments. Whereas if you think it's an enteric organism likely, so things that often can also cause a UTI, they've got a lower risk for STI, then you either got a choice of ofloxacin or levofloxacin. So if we go back to the options, just want to highlight that you need to have the knowledge, both in terms of making the diagnosis and knowing the right guidelines for management, but technique is really important, reading carefully. So look, if you thought it was torsion, then you'd be admitted to hospital for surgical management. That's less likely with this presentation. If you thought an STI was likely, then you might be thinking about things like ceftriaxone and doxycycline. So ceftriaxone for gonorrhea cover, doxycycline for chlamydia. Ofloxacin, see, this is here picking up that ofloxacin should be a 2-week course, but the option in the question was a single dose. That's why C was incorrect. All right. And then azithromycin 1 gram orally as a single dose, that just doesn't fit. Okay, so you're left with this, levofloxacin 500 milligrams. Okay, question number 3. Okay, now this is again a 2-step question. So if I look at the answers, the split is between A and B. About half of you picked A, about half of you picked B, just under half for both of those. Very few people picked the other option. So what we're trying to work out, in terms of sore throat and antibiotics, here the question's asking about the fever pain criteria. So you see the first step is working out the fever pain score, because that's going to tell you what does a guideline say you should manage it based on that score. So that's the first step, right? So let's work that out. Type into the chat, what do you think this patient's fever pain score is? And again, you see, if you get this first part wrong, often it will lead to you getting the second part wrong. Okay. So we've got options ranging from 1 to 3. So quite a lot of people have picked 2, quite a lot of people have picked 3. Any 4s? Yeah, I think I've got a 1 4, and then some 1s. All right. So there's a big spread. All right. So this patient's fever pain score is 3. And therefore the right answer is B, according to the guideline. So why is their fever pain score 3? Well, fever within the last 24 hours, and that includes self-reported. So the mother reports that it was earlier today, it was 38.1. So they score a point for fever. That's the fever in fever pain, right? Then P is pus. They haven't got pus, so they don't get a point for that. A is attending rapidly. So if they come within 3 days of symptoms, so they've had the symptoms for 2 days, so they get a point for the A. Okay. I is inflamed tonsils. So the tonsils are inflamed. They get another point for that. So that's 3. Okay. And then the N is no cough or coryza. It's not 2 separate points for that. Okay. So if they either have a cough or they have cold-like symptoms, runny nose or blocked nose, you do not get a point for the N. To get the point for the N, they have to have no cough, and they have to also have no Neither of them have to be there. They've got one of them. Look, they've got runny nose. Therefore, they don't get a point for the N. So that's why it's 3. Okay. And so what does the guideline say? Well, 2 to 3, you should consider a delayed script. That's why the correct answer is B. All right. 0 to 1, then it would be no antibiotics. And so those of you that picked that option, you probably calculated it as 1. All right. 4 to 5, you'd consider giving antibiotics on that day. A few people had picked that. And if you're going to give antibiotics, first line is Pen V. There's no mention of any allergy, you see. So first line is Pen V. It's only if they had an allergy to penicillin, then you might use clarithromycin or erythromycin. And that's typically even for 5 days rather than 10 days. Okay. So the first part is working out that fever pain score is 3. So as I mentioned, fever within the last 24 hours, that includes self-reported. So in this case, the parent, it doesn't have to be that we've measured the temperature now. They had that temperature earlier in the day. So even though they're afebrile now, it's still in the last 24 hours. So they get a point for that. Okay. And then the other bit to be conscious of is the N. That is no cough or coryza. So if they've got either one of them, they don't get a point for N. And they had a runny nose, so therefore they had coryza, so they don't get any point for that. Okay, question number 4, admin. Okay, so stop it there. This one, the key thing is just picking up, because a lot of people just see access to health records and they very quickly jump to data protection without actually reading the full question carefully. So the key thing is that this patient doesn't want access to their own records. They want access to their father's records who's passed away. And they've got 2 of the things that often give someone a right. One is if they're the next of kin. The other is if they're the executor of the will. This person is both. Okay. So the correct answer here is E. Because if you want to access someone else's records who's passed away and you have a legitimate reason to do so, in this case, they've got the fact that they're next of kin, that they're executor of the will, and they want to take legal action because of possible negligence. That's why they've got the right. But you need to apply under the Access to Health Records Act 1990. All right. As I mentioned, the common mistake is people just see access to health records and they think of the Data Protection Act. What would you use the Data Protection Act for? To access information about yourself. You can't use that to access information about, in this case, someone who's passed away. Okay. So that's why E is correct and C is incorrect. C was the second most popular answer. Well done. Most of you did pick E. So that's great. So 3 important bits of legislation in relation to health records. So the Data Protection Act 2018 is what we use if we want to access our own information. So if I wanted to access information in the GP record at my practice, where I'm a patient, I'd apply for a subject access report under the Data Protection Act. Okay. If you want to access one of your employees' information in relation to occupational health, companies would apply under the Access to Medical Reports Act 1988. And if you want to access records of someone who you've got a legitimate interest to access their record, like your family member, next of kin, or executor of the will, and you think there might be negligence, but they've passed away, then you apply under the Access to Health Records Act 1990. Okay, and that's what this question was about. Okay, this one's about data interpretation. Great. Really happy to see that most people have got this right. So the question's asking which area had the worst mortality rate for women under 75. So the correct answer here is D, Doncaster. Okay, so the key thing is to make sure that you're looking at the right row. So the question says worst mortality for women under 75. So you see, look, we've got mortality rate for all causes. That's what mortality is any death for any cause in women, female. So you're looking along this line and you're looking for the worst. So what you're looking for is the highest number. This is deaths per 1,000 people. You can see Doncaster had 324 deaths per 1,000. That's therefore the worst. So common mistakes. Sometimes people, they see women under 75, but they miss that it says worst mortality. That's all cause. Whereas you can see if you looked at cardiovascular mortality here, so you're still looking at women, if you're specifically looking at these are only deaths related to cardiovascular disease, you can see for that, Bradford has the worst. And that was the second most popular answer. Okay. Similarly, if you looked at men and all-cause mortality, Bradford. If you looked at men and women, all-cause mortality, Bradford. So that's the common mistake people make, is that they're looking at the wrong row. All right. And this is an example of real-life data, taking this from public health. So other types of new style data interpretation questions that you might get, prescribing data, regional disease incidence and prevalence, other types of public health data like cancer rates, differences between splits in population at different age bands between male and female, or children and older adults, mortality rates, but also more classical graphs and charts, interpreting research graphs. Okay, so some examples. Okay, this is an example of a breakdown in different population age bands for a particular practice. Actually, it's a practice where I've worked on and off for 15 plus years as a GP. Okay, this is an example of prescribing data looking specifically at some types of antibiotics, broad spectrum antibiotics specifically, okay, because one of the quality indicators. This is an example of what's called a quinary graph. So what we've got is 5-year age bands, and you've got male and female patients. Again, this is for a particular practice. This is infant mortality data. This is called a leaf plot, looking at pre and post test probabilities based on sensitivity and specificity. This is a Kate's plot or smiley face graph. Okay, these are examples of types of things you need to know how to interpret. Okay, right. So, any questions? Put them in the Q&A. The team will pick some up. But we're going to move on and take questions later on. Now, if you found that style of learning helpful, we do one question at a time, 55 seconds, then go through immediately a breakdown of why the right answer was right, why the other popular answers might have been picked in terms of exam technique, and then a rapid review of the relevant guideline. That style of learning is the style that we use in our masterclass webinars, which are coming up. So, we have the live sessions this weekend. On Saturday, we have Statistics Made Simple, 4 hours covering key stats topics, including the new style data interpretation. All of those graphs I showed you, those different types, we'll cover all of those and more. We've got organizational domain organized. So that's the admin domain, key topics from that. Again, a half day. That's on Saturday in the afternoon. And then High Yield Clinical Grammar 1 and 2. This is covering the clinical topics mentioned by examiners in recent examiners reports. These things are often retested. That's next week on Wednesday evening and Thursday evening from 7 p.m. to 10:30 p.m. So you can book all of them for £299. That's a saving of nearly £150 compared to if you book them all separately. Okay. You also get access to the recording for a month afterwards if you book any of the live sessions, or if you're not available at all for the live session, you can just directly subscribe to the recording. They're available for all of those. Okay. So Stats Made Simple, we'll cover all these topics and more. So we'll do 45 questions in that format, but we'll cover more than 60 key stats topics. And we've had lots of people, turn what they used to fear and was their worst domain into their top domain. Lots of people get, 85, 90, 95, 100%. And then admin, we'll cover all of these topics and more. And again, 45 questions in that half day, but more than 60 topics covered from the admin domain. And then High Yield Clinical Grammar 1 and 2, 90 questions across the 2 evenings, but over 100 different clinical topics. But every topic was mentioned in examiners' reports. Okay, so we're going to move on now to the mini mock exam. Here, slightly different format. You will see 10 questions, one after the other. There'll be no polls. You won't see or hear me during that whole 10 questions. and they'll move forward automatically every 55 seconds. So just write down the number. You see the questions are numbered from number 6 because we've done 5 questions already. So just write down number 6 to number 15 and write your answers down at home. Don't put them in the chat. Don't put them in the Q&A. Just write them down at home. After you've done all 10, I'll then go through answers, explanations, and teaching for all 10. Okay, here we go. Okay, well done, everyone. So mark your own. You get 1 mark for each correct answer. I'll remind you of the question, then I'll tell you the right answer, and then we'll do the teaching. I won't launch polls for this so that we can get through all 10 questions in time. Okay, so question number 6. In every single AKT, there will always be at least 1 drug calculation question, and usually there are 2. So usually 1 to do with cancer pain and 1 pediatric dosage conversion or calculation. Okay, so the correct answer here is C, 80 milligrams. So the key to this is that they're on morphine sulfate, 120 milligrams BD. So you need to calculate the total morphine they're using at the moment. They're well controlled on this dose. So 120 twice daily, that's 240, isn't it? Okay. So that's the first step, working out their total opioid need at the moment. And then when we're converting from oral morphine to diamorphine injection, so this is a syringe drive, isn't it? Okay, continuous subcutaneous infusion. That's what CSCI stands for, syringe driver. You just divide by 3. So 240 divided by 3 is 80. So the correct answer is C, 80 milligrams over 24 hours. That's because diamorphine is about 3 times as strong as oral morphine. The common mistake in this is that some people miss the BD. So they do 120, they know the conversion is 3, but they divide 120 by 3, so they end up with 40. So they get that wrong because they missed that this is twice daily. And the other one is that people either miss that it's diamorphine or don't know the conversion. And what they do is they do 120 twice daily, 240. They divide by 2 and get E, which is incorrect. That's the conversion for morphine rather than diamorphine. So morphine by injection is twice as strong as oral morphine. Diamorphine by injection is 3 times as strong. So if you're going to change to a syringe driver, which is particularly useful, near the end of life as part of palliative care, you calculate the 24-hour oral morphine requirement. That includes any breakthrough doses. This patient had stable pain. They had no breakthrough doses used. And then if you're changing to morphine, which you can give in a syringe driver, you divide by 2. More commonly, we use diamorphine in a syringe driver because you get a stronger concentration. You get, higher amount with a smaller volume. And so you divide by 3. And this table is taken directly from the BNF, this conversion table, to the section at the beginning of the BNF, which covers prescribing in palliative care and pain management. Okay, so key thing here, genetics. We've got 2 carriers for hemochromatosis. Type into the chat, what's the nature of inheritance of hemochromatosis? What type of inheritance does it follow? Okay, it's autosomal recessive. Great, okay. So both are carriers, and they want to know what's the risk their children will have the disease, not become carriers, but have the disease. So here, it's reading that carefully, okay? So what's the risk that any children they have will have the disease? It's 25%, because if they're both carriers, it's 1 in 4 that their children have the disease. Whereas the second one in the set, you see extended matching questions, they come in sets of 2, 3, 4, or 5. See, this is genetics 2 of 2. So here the question is, what's the risk that their children will become carriers? The risk that their children will become carriers is 50%. Okay. So autosomal recessive inheritance. Look, we've got mum is a carrier, dad is a carrier. So mum's got 1 hemochromatosis gene and 1 normal gene. Dad's got 1 hemochromatosis gene and 1 normal gene. So you get 1 from your mum, 1 from your dad, right? So if they're unlucky, they'll get the hemochromatosis gene from mum and from dad. This will have full-blown disease. There's a 1 in 4 chance of that, right? 50-50 chance you get 1 healthy gene, 1 normal gene, and 1 hemochromatosis gene. So 50-50 chance you become a carrier. And 25% chance you get normal from mum, normal from dad. Not only are you not a carrier, you cannot give it to the next generation. Okay? So that's autosomal recessive inheritance. And it's worth knowing the modes of inheritance of some of the relatively more common or more important conditions for the UK population. So I've listed those here. Okay, question number 9. Here, this is a challenging question for 2 reasons. It both asks for 2, so it's a multiple best answer. You've got to get them both right. That makes it more challenging, because if you get 1 right and 1 wrong, which often people do, you get nothing. There are no half marks. But it's also negatively framed. And it's the only negatively framed question that we've seen so far. Okay, that's because the majority of questions in the AKT are positively framed. They ask, what is the diagnosis? What is the right test? What is the right prescription? What would you do, rather than what would you not? But sometimes you get a question which is negatively framed. So look, which of these would not be recommended as part of the diagnostic workup for this patient. Okay, so this patient's got oligomenorrhea, erratic periods over a year, but still having periods. But while that's been sort of 6 to 8 weeks, then had no periods at all for 3 months, then restarted, got some mood changes elsewhere, no other illnesses, otherwise healthy. So the correct answer, A and H, would not be recommended. Now, almost everyone picks H, but sometimes people miss A. So they pick one of the other ones alongside H, so then you get no marks. You need both right if you want to get the answer correct. Okay. What is it that we're suspecting? What is it that we're looking for? This patient's under 40. That's important, right? What we'll be thinking about is premature ovarian insufficiency. Okay. Sometimes described as premature ovarian failure. All right. So if we look at the guidance on that, when should we suspect it? Someone under 40 who's not on the combined pill, who's got menopausal type symptoms. This lady had some of those symptoms with either infrequent or no periods, or a period where that happens and it spontaneously starts back. So what you might find is that the FSH is raised, so 30 plus on 2 samples taken at least 4 weeks apart. And then other things that you might do as part of the workup, check LH, estradiol, prolactin, TSH, testosterone. The guideline specifically says that we should not routinely perform a pelvic examination in these patients. She didn't have any other symptoms. She didn't have any other, she was otherwise healthy, okay? But in trying to diagnose this, and that's what the question was asking, it was asking what would not be recommended as part of the diagnostic workup for this patient, okay? And it also does specifically mentions that it doesn't recommend doing AMH testing for diagnosis, okay? So that's why not those two, but you need both to get the mark. Okay, so admin domain, got this family of a patient who's given a gift. So which two are correct? Again, you need both right to get the mark. So they are B and F. So if a patient or a relative gives you a gift and you didn't ask for it, unsolicited, they may be accepted in some situations, as long as it doesn't breach the GMC guidance on when you can and can't accept gifts, which we're going to cover now. Then in some situations, they may be accepted. That's why B is correct. And then F, there's no maximum value. The common mistake is people pick E, but this is specifically asking about GMC guidance. The GMC doesn't set any maximum value. Those doctors working in a GMS practice, GMS is one of the 4 NHSGP practices, contract types, GMS, PMS, APMS, PCLMS, okay? Under that contract, there's a rule about high value gifts, £100 or more, but that's nothing to do with GMC guidance, which is what this question is testing, okay? So GMC guidance, it lays out when we can and cannot accept gifts. So we're not allowed to encourage or pressure people to give gifts. We shouldn't pressure patients to offer donations, even if it's to a good cause like a charity. And you're not allowed to alter the management that you offer or the services that you offer based on a gift, because then it's going to be a bribe. And you shouldn't accept a gift if it might be seen as a conflict of interest. You know, like if the patient's got dementia, for example, don't accept the gift. They might not understand that they're giving it freely. They might feel they have to give it to you, all right? But as long as none of those apply and they give it voluntarily, they can be accepted. And GMC doesn't set any maximum value. Whereas if you happen to work in a GMS practice, that's nothing to do with the GMC. Practices under the GMS contract, there's a rule that gifts worth £100 or more should be recorded in the register of gifts. That's nothing to do with GMC guidance, which is what this question was testing. Okay, question number 11. So, key thing here is that this patient has got synovitis affecting small joints of hands and feet. So we've given painkillers, we've ordered blood tests. The most appropriate next step is what's called sometimes a very urgent referral. So within 3 working days in the context of suspected rheumatoid arthritis. Okay, so A is the correct answer. So common mistakes, people often pick 3 weeks, which is the default that we normally refer people with suspected rheumatoid on. But the reason she needs one within 3 working days is small joints of the hands and feet. If either of those are affected, that's one of the indicators for a 3-day rather than a 3-week referral. If multiple joints are affected, or if they've already had symptoms for more than 3 months, i.e. they've already got progression, these are all indications for a very urgent, so 3 working day. Whereas anyone with suspected rheumatoid, even if they didn't have these, it should be within 3 weeks. And while we would do the bloods as part of the workup, don't wait for the results to do your referral. You should still do the referral. Don't delay that referral, because, you know, if someone has got rheumatoid, the sooner they get onto disease-modifying anti-rheumatic drugs, especially if they've already got progression, the more likely we can prevent it getting worse. Okay. Question number 12. So, units of alcohol. The correct answer here is D, 27 units. Now, there's an easy way to do this. And that is that if you know that a large glass of wine of a typical strength, and this is typical for wine, has got 3 units in it, then all you need to do is count. So 7 nights a week, she has a large glass, so that's 7. And then on Saturday and Sunday, also has another large glass at lunch. So that's 7, 8, 9. 9 times 3, 27. That's the easy way. The other way, if you don't remember exactly how many, is if you know the formula. So the formula to calculate units is volume in milliliters multiplied by the alcohol by percentage volume. Take that total and divide by 1,000. So volume in milliliters, 250 mils times 12% alcohol by volume. Take that total. I'll do it with you so you can actually see it. If I make this small so you can see me do it. There we are. Okay. So look, we've got 250 mils times 12% alcohol by volume. That's 3,000. Divide that by 1,000. You see, that's 3 units. And then it's 9 glasses. So times that by 9, get 27 units. Get the same answer. But if you remember how many units are in common typical drinks, this is really quick way to do it. For a lot of people, you might be able to do that in your head. Okay, but this is the formula if you want to be perfectly accurate. And this is how many units of alcohol are in common drinks. So wine at about 12%, small glass, 125 mils, is 1.5 units. A 250 ml large glass is 3 units. Beer, standard strength beer, is about 3.5 to 4%. Roughly 1 pint is 2 units. Premium beers and lagers, 5 to 6%. A pint's about 3 units. Spirits, 25 milliliters, sometimes described as a single shot or single measure in the pub. 1 unit of any spirit at 40% is 25 mils. Okay, so 25 mils of, whether it's whiskey or vodka or, doesn't matter, any spirit at 40%, which is a typical strength for spirits sold in the UK, 25 mils or a single shot is 1 unit. And cider is often strong, typically similar to premium beers and lagers. A pint's about 3 units. Now, if you want to be precise, this is how you calculate it. Take the volume in milliliters, multiply it by the percentage alcohol by volume, divide that by 1,000. Okay, now, does anyone know, because they might describe it, how a patient would give you a history? Patient's not going to say, I drink this many milliliters of beer. They're going to say, I had a pint or half a pint. So you need to know how many milliliters is in a pint. Type into the chat. How many milliliters is in 1 pint? Because in the UK, we still use imperial measures for a lot of things, right? Rather than metric. So the right answer is 568 milliliters. You see, if it was 500 milliliters, it'd be easy, because you can divide things by 1,000 easily, and therefore you just take half of that. But it's 568 milliliters is 1 pint. Okay. Question 13. Really interesting. You know, I was in clinic today, and I had a patient where we had this almost this exact discussion. So patient already on 2 different oral anti-diabetic medications, but got really poor HbA1c control, been monitoring their sort of BMs for the last 2 weeks or so. Again, high nearly every day. So started on a 3rd anti-diabetic, but we had that discussion that, look, when you've had diabetes for as long as you've had it, sometimes the body doesn't respond as well to the tablets. And so if once they're on 3 now, if they still don't improve, that the next step is we might need to go on to insulin. We had that discussion today. That made me think about this question. So the correct answer is B, NPH. So NPH is an intermediate acting insulin, and continue the metformin. One of the keys for that, and why not, for example, starting a short-acting insulin as well as NPH, is that the HbA1c is 70. If that was above 75, then we might go to this and add in a short-acting insulin as well. Okay. So NPH, an intermediate acting insulin, you can either give it once daily or twice daily. So what I would commonly do, if I had a patient like this patient on multiple oral anti-diabetic medications and the poor control, I'd stop the others. I'd keep metformin as a baseline, and then I'd put them onto NPH, and typically I would start that just as a once daily given at night. And then they're still taking their metformin as normal, which gives them some cover. And then I'd see how they get on. And for a lot of patients, that's enough. If not, you can then consider either doing twice daily or adding top-ups, at meal times with a fast-acting, short-acting insulin. But that would be the typical starting regime. Keep them on the metformin, put them on NPH. As I mentioned, if their HbA1c was even worse controlled than this patient was at 70, if it was 75 plus, then you might go straight to NPH and a short-acting insulin. When to consider long-acting, so detamir and glargine are long-acting, okay, instead of NPH, if there's someone that struggles with injections, or if they get lots of hypos, and that having symptoms to do with that. And then once you put someone on insulin, you're going to regularly monitor their blood. So typically you measure it once in the morning, once in the evening. This is so you can see whether they need to adjust and get a short-acting insulin as a top-up around meal times. Okay, so type your answer into the chat. It is an example of a free text question. So in the exam, if you get a free text question, you can see there's no A, B, C, D, E to guess from. You type your answer using the keyboard. So type your answer, and then I'll see what people have put. And then we'll see if you've got it right. So correct answer is 41,560. Okay. That's the only thing that will get you a mark. Now, if you typed this and then added to it per million, that would be okay. As long as the number is correct, you'd get the mark. If you put any other number, or if you put .39, like if we were to be exact about this, is 41,560.39, you still wouldn't get the mark. Why? Because the question specifically asked to type it to the nearest whole number, not to 2 decimal places. So that's the exam technique, reading carefully. So let's do the calculation. All right. Incidence, that's what the question asks about, right? Incidence of COVID-19. So is the number of cases divided by the population. So this is the number of cases, and this is the number of deaths. Common mistake. People look at the deaths. If the question asked about mortality, COVID-related mortality, then we care about this number. But it didn't. It asked for the incidence of cases. Okay, so we look at, these are the cases. So we've got this many cases divided by the population, which is given. That gives you this number. But it asked for this per million. What some of you did, you, instead of multiplying by a million, because it's per million, this last step, you multiply by a million, which gives you 41,560.39. We round that by looking at the number after the dot. If this number is 4 or lower, then this is the number to the nearest whole number. If this number after the dot was 5 or higher, we add 1 to this number. So if this was 0.59, for example, then it would be 41,561. You round up when the number after the decimal is 5 or higher. If it's 4 or lower, you round down. That's why it's 41,560 to the nearest whole number. Okay. So common mistake, instead of multiplying by a million in this step, people sometimes multiply by 100. And so you would have got an answer of 4. What's that? That's percent. Okay. That's percent. The question didn't ask for it per, there are some things we will calculate as a percentage, but the question didn't ask for it as a percentage. They asked for it per million. Why? Because this is how the WHO recommended, and this is how we reported incidence of COVID, so that we standardized with all other countries, so we could compare per million. So they've used exactly what we were asked to use in the real thing. Okay. Remember, you have an on-screen calculator in the exam. They're not expecting anyone to do any of this in your head. You click the on-screen calculator button, which is in the top left corner in the exam, and you use that. Okay. So incidence is the rate of new cases of a disease. You can either report as a percentage or as a proportion, like we did in this question. So typically you look at it over a year. So, how many cases, divide that by the population. If it asks for it as a percentage, you multiply by 100. Remember, percent just means per 100. You're always multiplying by something at the end, whatever it's per. So if it's per 100, that's percent. If it's per 1,000, you'd multiply by 1,000. In this case, it said per million, so you multiply by a million in this last step. Okay. Right. Last question. prescribing in pregnancy. Okay, I'm actually going to launch a poll on this one just because this guidance has just changed, and often when there's a recent change, they'll test that. And so some of you just might not know that this guidance has recently changed. That's why it's worth looking into it. Okay, great. So the most popular answer is A, that NSAIDs are contraindicated at any stage of pregnancy. That's actually more than a third of you picked that. The second most popular answer is this one, that additional monitoring is required if it's from 28 weeks onwards, only required if it's 28 weeks onwards. The correct answer, though, is actually D, that the MHRA, there was a recent MHRA, that's the Medicines and Healthcare Regulations Authority, okay? They advised additional antenatal monitoring might be required from 20 weeks onwards because of a new study, whereas previously it's always been contraindicated to use NSAIDs, for a long time, 28 weeks onwards. That's where some of you will be familiar with this number, and that's what made you think about this. All right. So the most popular answer, really interesting, was that NSAIDs are contraindicated. They're not contraindicated because they can be used in first trimester and in the early part of the second trimester with caution. It's recommended that unless it's essential, we don't use it because there are some risks, but it's not, look at the word, it says contraindicated. It's not contraindicated. That's why A is incorrect. Okay, so let's look at this update. So first of all, MHRA alerts. They put out alerts about important drug safety changes, and these things are often tested in the exam. Because if the known safety of a drug changes, that's something that we need to be conscious of if we're going to be up to date and be evidence-based practitioners, right? So for a long time, we've known to avoid NSAIDs in the last trimester, 28 weeks onwards, because of a risk of premature closure of the ductus arteriosus. It can cause renal dysfunction in the baby. It can prolong maternal bleeding time. It can also have an impact on contractions during labor. So for a long time, it's been, considered contraindicated in that bit, and that it can be used with caution if it really has to be in the first and second trimester. And that it's a class effect. So ibuprofen, naproxen, diclofenac, these are the common ones, but really any NSAID. But this new study looked at the increased risks with prolonged use from 20 weeks, i.e. earlier. So the latest alert mentions that there's this risk of oligohydramnios because of that renal dysfunction, even from 20 weeks onwards, and that it can also lead to problems with the ductus, which can lead to heart dysfunction. So they now recommend that we consider monitoring for oligohydramnios if the mother's had NSAIDs for several days at or after 20 weeks, and that we should avoid prescribing 20 weeks onwards. We should advise that they don't buy over the counter 20 weeks onwards. Okay. So add up your score. You get a total out of 15. We had 10 in the mock and we did 5 in the first part. So add up your total. So if you've got 11 or more, well done. That would be a pass on any sitting of the AKT historically. 10 would be borderline. It'd just be a pass in some sittings. It'd just be a fail in some sittings. 9 or less, don't worry. You're not sitting the exam tomorrow. If you're sitting the exam tomorrow, 9 or less, you're not ready. But you've got at least 7 weeks, and some of you aren't even sitting in January. Some of you are going to be sitting in April, and you've come early. Most of you are sitting in January, right? That's exactly the point, that you've still got a lot of time, right? Hopefully, you've got an idea of some gaps in knowledge in terms of curriculum areas. Maybe you didn't know about that recent update, for example, but also some of these questions, you might have actually learned the topic, but you missed some of the keywords, or you misread the question, you missed something important in the scenario. So technique is also really, really important, okay? So don't worry. The point is, also, if I'm going to cover 15 topics today, I'm going to cover topics that we know people struggle with, right? So that you gain from the session, there's more to learn. So let's talk about revision planning. Last 7 weeks. By this stage, you should have already covered a good chunk of the curriculum. What you want to do between now and the exam is systematically cover any gaps, any weaker areas in the curriculum, and then you should aim to make sure you've covered everything by the time you get to the exam, and you should go over again key stats, key admin, and all of the high yield clinical topics as we get closer to the exam. In the last 30 days before the exam, I will post a video each day in the GP training support group, where there'll be a question, and then there'll be like an answer and rapid revision, and there'll be some revision tips. Okay, so watch those without even spending more than 5-10 minutes a day. You're covering 30 topics, and work on exam technique by continuing to work on your online revision questions, doing some timed mocks. Again, those of you that are on the program, we'll do one full-time mock each week in the lead up to the exam. So you get used to that timing, you get used to consolidating your knowledge and filling in any gaps. Okay. You can download our curriculum checklist. I'll send links to that in the post-course email that I'll send out by the end of the day tomorrow. Okay. Those of you on the program, you've already got the printed version, you've already got access to it. And then it's also worth going through our high yield checklist, which again, I'll provide a link to where you can get this from, which covers topics that examiners have mentioned as problem areas or important areas. And these things are always frequently retested. That's not all of them, by the way. I'm just showing you an example, but you can actually print this or make sure you've covered it. So in terms of reading between now and the exam, look, if there's a specific guideline you want to look up NICECS. If you want to cover lots of them quickly and you don't already have our clinical case cards, all of you on the program already have this, but you might find that helpful as a way to cover lots of them quickly and efficiently. So there's 112 topic reviews. They're up to date. The latest edition, the 11th edition, was published in 2023. So it's up to date. And there's a printed version. There's a digital version. There's a bundle where you can get both. Okay. Some examples there. Also, how we did one question at a time in the first part? That's how the masterclass webinars on stats and admin and high yield clinical running this weekend and next week run. But how we did that 10 question mini mock, all 10, one in a row in a time. That's the format of our AKT 200 question mock crammer. So if you found that helpful, you might find that useful to join to help boost your learning and your motivation, and just also consolidate a lot of topics and work on your time management in the lead up to the exam. So the next live one is the 6th of January, 2024. It's a full day, 9 a.m. to 6:35 p.m. And the way that works is you do 50 questions all in one go, move forward automatically every 55 seconds. Then I go through answers, explanations. You get a topic review, a PDF that you can download. We go through those 50 topics. Then we have a break. Then we do another 50. Then it's lunch break. Then another 50. Then you have a break. Then another. So by the end of the day, we will have covered 200 unique questions. We'll have revised 200 topics with rapid reviews in the same proportion as a real exam. 80% clinical topics, 10% stats, 10% admin, all in one day. Then you get access to another 200 question full online mock with 200 different questions that you can do at your own pace. It's got standard timing, it's got extended timing for those that get 25% extra for things like dyslexia, for example, or other forms of neurodiversity. So you get that after to continue your learning. So that's 6th January for the next live one. And just a recap of our bundles for those of you that want support. By the way, if you're on our Pass Guarantee program, you're already booked for all of this and you will already do all of the mocks. So don't worry about this bit, okay? But for anyone that's not already on the program, the 3 bundles that we have that offer some or all of these things. So our AKT Pass Plus bundle, it covers the recordings, because both of these already happened, of a half-day AKT masterclass and our full-day AKT preparation course, which was last weekend, which is 7+ hours, okay? So the updated recording of that will be included. And then you join live and access the recording for the full-day 200 question mock crammer in January. It includes the half-day stats, half-day admin, the high yield clinical crammer 1 and 2 next week. It includes our online question bank, which in total is over 2,700 questions, including mock A, B, and C. And it includes the printed clinical case cards delivered to the UK. So about 130 hours worth of learning. That's 749. If you were to buy all of these separately, it'd be over £1,000. So it's a big saving compared to that. The booster bundle includes the AKT 200, the stats, admin, the high yield clinical webinars, and one mock B. It doesn't include the case cards or the other full day course that already happened. And then the masterclass bundle is the 4 webinars. So stats, admin, clinical crammer 1 and 2. Okay. So all of these compared to booking separately, they give significant savings. Okay. Someone will post a link to where you can get all of those coming up. All right. So any questions? I'll take those. For those that don't have questions, I just want to leave you with this reminder from Muhammad Ali, that as we get close to the exam, it's really important to remember this. Don't count the days, make the days count. Every single day between now and the exam, make sure you're making progress, that you're revising some topics, you're practicing some questions, you're reading over some guidelines. You might already have made notes on some topics, go over some notes. Don't let a single day between now and the exam escape you, whether you're striking or not striking. I appreciate that, people have time off, there's Christmas, New Year, you'll have family get-togethers. By all means, you want to take part in all of that. But at some point, even on those days, find somewhere to do, even if it's just a few questions, even if it's just to revise one or two topic reviews, go over one or two case cards, recap one guideline, look over one page of your notes. Don't let a single day go between now and the exam where you're not doing something. Make every day count, because the sacrifices that you make between now and then are going to pay off when you get that big green tick and you've passed AKT. And then, some have already done your SCA or your RCA, but the rest of you get through your SCA. Then the fun begins. The fun part of GP is life after CCT. GP training isn't fun by and large, okay? It's a lot of hard work and a lot of stress with the e-portfolio and all of these other things, but it's something you need to get through, right? So the sacrifices that you make now, if you make these days count, you can relax afterwards. You can treat yourself, you can, have a big break, go on holiday after you've done your exam, okay? So just make every day count. So for those that haven't got questions, thank you so much. I hope you found it helpful. Thank you for joining and giving up part of your evening. For those of you on the program and those that have already booked for this weekend, I'll see you on Saturday morning, 9:30 sharp. We start with stats. And then for those joining for admin, that's 2:30 in the afternoon. Okay. Thank you so much. Have a great evening.